Hi everyone, it's Dr. Steph. I'm an assistant professor at the University of Toronto where I teach the financial literacy curriculum. Recently, I worked with two residents, Drs. Abir and Vivesh Patel, on an academic project to develop and evaluate this lecture as a resource for new family doctors. As we already know, a lot of family doctors are retiring and new grads don't want to start new practices and become small business owners. So hopefully, by providing more resources to new grads like this, it will ease the transition to practice and reduce burnout. So the FHO, or the Family Health Organization model, is a type of billing model for Ontario family doctors, and it is the most complex billing model. It is complicated because it is like learning a new language. There are a lot of rules, and sometimes those rules change frequently. So it took me almost a month to think about how to teach this in an organized and simple manner. So I've broken it up into two parts, and I'll also try to give some tips that our clinic uses when billing as well. If you do have any additional tips for the new grads or new family doctors, please leave a comment down below. So to talk a bit about my own practice, I do addictions and family medicine. I have a roster of about 900 patients, and I work 2 full days of family medicine as the FHO lead. And then on the other days, I do addictions inpatient and outpatient clinics. So in this photo, I'm with the team of students and residents in my addictions clinic. In terms of what else I do in the other time, I also develop and give lectures, as I am doing here with the undergrad medical students. I do research, and I also have an administrative role at the hospital when it comes to doing EDI work. On the weekends, I record my lectures so that learners across Canada can access them for free. And I also supervise, psychiatry and family medicine residents and clerks 5 days a week. So if you want to join me in clinic, feel free to reach out, leave a comment, and then also feel free to support the channel with a like or subscribe. I don't have any conflicts of interest to disclose, so these slides were just made as part of an academic project with 2 PGY2 residents who are at Sunnybrook. I just want to give credit to all of the residents at Sunnybrook whom we've tested this lecture on, as well as Dr. Sharon Domb and Dr. Singh, who is part of the Department of Family Medicine at McMaster and also chair of the OMA section on palliative care. So I always want to start with the resources because that is literally the most high yield part. So 90% of what you have to know probably comes into these couple of next slides. So first of all, if you're following along with this lecture, especially as you go into the practice cases section, I do encourage you to have a second screen open where you can search up codes using these resources. The first resource is the 𝗧cie𝗽𝗶𝗰𝘀 Billing Codes document. And so this is a very condensed document that can be really helpful for just doing a quick search of different billing codes. The one downside is that it is a bit outdated. It's from 2015. So I think if they ever end up making a new one, I will link that in the description below. The other resource that I really like is the First 5 Years in Family Medicine, Family Practice Facebook group. I like this resource because it doesn't just have people in the first 5 years in it. There are people who are past their 5 years and extremely experienced in their knowledge of not just practice management, billing, but also when it comes to clinical cases. So when you're not too sure about what to do about something either clinically or ethically, like this can be a good place to ask your colleagues. The schedule of benefits is a very massive document, and if that 𝗧cie𝗽𝗶 document that you have doesn't really give you what you're looking for, or you want to go into a deeper dive into certain billing codes, you can look them up in the schedule of benefits. Now, just something to note is that there is a FHO physician's billing guide, but it is a bit outdated as there are some codes on there that are now obsolete. So for example, like you used to be able to get $5 per patient rostered, but not anymore. So I guess the only thing is it might be able to provide some helpful info on rejection codes or what the bonus that you're getting is for. Or let's say when you're reading through your RA or remittance advice, which is like a receipt that you get from the Ministry of Health, you can kind of look through that to get some understanding of the items on your RA. So like I said before, billing codes are changing constantly. And in fact, in the span of 1 year, a lot of the virtual care billing codes have changed. Usually I will add updates to the description or pinned comment part of this talk, as I can't edit a video once it's been uploaded. So if you also want to get updated information, this is where you can find it as well. And just for a refresher on billing, because let's say you're not working in a FHO or you just want to get some baseline understanding of billing, feel free to check out these 2 lectures that I've recorded in the past for residents as well. And if you want to know a bit about some of the changes that's been happening to the billing codes, please check out the pinned comment and description section of those videos. Now, when it comes to different billing models in family medicine, there are so many different types, so many different acronyms out there. Today, we're going to be focusing specifically on the FHO model, billing model, but everything else, like the FIG, fee-for-service, and FIN are other types of billing models. Feel free to watch this particular video. I'll link it above and in the description for a bit more of an overview on all of them. But for today's purposes, we're going to focus on the FHO model. So the main difference between the FHO model and the other models is that it's meant to incentivize comprehensive and preventative care, whereas a model like fee-for-service may incentivize volumes of patients seen, for instance. So how does this capitation work, and how does capitation help incentivize comprehensive care? Well, a capitation is kind of like a subscription fee that is paid per patient to you on behalf of the Ministry of Health, on behalf of OHIP, for you to provide their care, to care for them as a whole. And note that all key terms in my lecture is in blue. Now, capitation consists of a base rate, which is paid to you based on the age or the sex of the patient rostered to your practice. So for example, this 24-year-old male, you might get $90 per year on that patient. Or you might have another patient, 24-year-old female, you might get $199 for them instead. On average, it comes out to be about $280 per patient per year. So let's dive a little bit deeper into this because it can be a bit more detailed than that. So capitation consists of the base rate. So the base rate is basically meant to kind of mostly replace those fee-for-service billings otherwise billed in a FIG model or in a fee-for-service model. And it includes the comprehensive care payment, so, as part of providing that comprehensive care. And then also includes an access bonus, which is deducted from your base rate if there is a lot of outside use. And if there is no outside use, then the bonus gets paid back. So this is a chart that I've kind of, which I've taken from this website down below. And it kind of gives you a little bit of the breakdown between the 3 components of what makes up a capitation. Now, it looks like it's like quite a lot per patient per year, but it's also unrealistic to expect to receive the full amount, right? Because sometimes, especially if you're practicing in an area with a lot of virtual walk-in clinics or in-person walk-in clinics, it can often reduce your access bonus by quite a lot. If your access bonus starts going into the negative, then it starts cutting into your group's access bonus. So your group meaning the clinic of where everyone else is working with you, right? All the other doctors working with you. And so it kind of depends on your governance model of your clinic to ensure whether there is some sort of payback policy. Often we have about 6 months to retroactively de-roster the patient. And so in that case, then the patient, if they're not on your roster, then they'll take away the capitation payments as reconciliation for the month, and you'll just get paid for them as a fee-for-service patient. So the other assumption, I guess, these charts make is that they assume equal distribution across age range, but in fact, roster income does vary quite a lot depending on age and gender distribution. So it's really hard to kind of answer the question, how much exactly do you make? But let's try to work through a bit of an example to help you understand. So generally speaking, a lot of doctors will ask, okay, how many patients should you kind of roster for how many days that you work? The general guideline is about 150 to 200 patients rostered per half day that you work. Let's assume that you work about 3 to 4 days a week. And the reality is most family doctors don't work 5 days a week simply because there is just a lot of paperwork that you often need one day as your administrative day to sort through all those labs, consult notes, prescription refills, and things like that. And the other assumption that we're making with this example is assuming that the patient does not use any outside services. So making all of these assumptions, let's say you have a 1,200 patient roster at that particular capitation per year, that comes out to be about 337,000. So that looks like it's quite a lot, right? And in addition to that, you might get shadow billing, which is a term I will talk about in a later slide. You also want to keep in mind, because you're a small business owner, you will have overhead that you have to pay, and that in general comes out to be about 30%. This can vary depending on the geographic location that you work. So after that, it is about 236,000. And you also want to think about taxes because, of course, you want to pay taxes. So let's assume using the 53.5% marginal tax rate, it comes out to be about 92,000 in terms of about the taxes you owe. And that ends up with about 144,000. So you also want to keep in mind, this income, it does not include all the time you spend doing paperwork, billing, reviewing charts and things like that, or participating in continuing medical education or CME. Those are all things that you would have to pay for yourself or do on your own time, and you're not really getting paid for that. In the past, you might see a billing code like 𝗧cie𝗃𝗶𝗰𝗀 to cover CME, but that is now obsolete. And also remember, not all doctors have 100% of their patients rostered. So it makes it more complicated to exactly figure out how much you make when there might be fee-for-service coming in, or there might be faux bonuses coming in as well, preventative care bonuses that I'll touch on in the next couple of slides. So how does this look like when it comes to comparing a FHO model with other payment models? So comparatively for the same around the same roster size, you might think that the FHO model does end up paying more. But you also want to keep in mind that the purpose of the FHO model is to incentivize comprehensive care, not rapid care. So I don't want you to just look at this slide and think, okay, I'm going to just roster a lot of patients, because you also want to remember the priority is to be a good doctor first. You want to provide good care, which means being available to patients. Rostering too much might result in a lot of outside use, which decreases your access bonus. And now there is also a cap to how many patients you can roster, and that cap is at 2,400. After that cap, you no longer really get that comprehensive care or base rate capitation. It's just kind of as like a fee-for-service model. So you also want to remember that with increased patient volume comes increased administrative burden, and that part is unpaid. So while you might be earning a high salary, you'll also be working quite long hours, maybe evenings and weekends. So you have to think about how much work-life balance you want to have. It's not always just about the income. Okay, so now let's touch on shadow billing. I used this term earlier, so what does it mean? Basically, shadow billing is when you bill for each billing code, but you don't get the full amount of it. You only get 15% of that code when you're working in a FHO model. And the reason why is because there are several billing codes that are considered in basket, which means that they're part of that subscription. You're already expected to provide those services. So you only get maybe like a shadow of that particular billing quantity. And also it might be a way for the ministry to kind of track what type of diagnoses you're seeing or how many patients you're seeing. if you're kind of billing for them and receiving a shadow billing code for it. Now, there are other codes that are called out-of-basket codes. And those out-of-basket codes, those are the ones you get to keep 100% of instead of a 15%. And often those codes are found in the OB or ER or palliative section of the SGFP document. So how do you know if something is like in basket or out of basket? You can tell by this little symbol right here, the N and the O. So basically the N just indicates that the code is an out-of-basket code if you're working in a FHIN, a family health network, or if it's an O beside it, it just means that you're basically working, you get that out-of-basket in a FHO. So that's like a visual trigger to help you recognize what is considered in or out of basket. So let's talk a bit about the pros and cons of working a FHO, because when a lot of people are graduating, they're thinking, okay, should I join a FHO or should I not? Or should I join any of the different other practice models out there? So the main benefit, I guess, of joining a FHO is that it incentivizes comprehensive care. That's the purpose of why it was created. So if you're someone who wants to provide, cradle to grave family medicine, working a FHO might be a good way to do that, especially if you want to do mostly family medicine. The other benefit is that because it's a capitation that's paid to you monthly, you still can get paid if you're taking time off. So for example, let's say you need to take time off to find a locum. It might be easier to do that comparatively to a fee-for-service, like enhanced fee-for-service type model like FIG or pure fee-for-service. Because, locums might not be able to see as high volumes as you can. And so it might be, you might be able to kind of pay them and still be able to afford a certain locum when you're in a FHO, for instance. Likewise, you also, if you do like the longitudinal type care, these patients are rostered to you, right? So these are your patients, and now you're responsible for their longitudinal care in the future. Now, what are the downsides of working in a FHO? Well, I touched on this. Billing is more complex in a FHO, and it can be frequently affected by policy, as we've seen in the past. People who use walk-in clinics or telemed services a lot can eat into your access bonus. Right now, for this year, the $57,000 cap on any sort of work that you might do for in-basket fee-for-service billings. So let's say you might have like a walk-in day, like a clinic day while working as a FHO doctor for just patients to walk in. They may not necessarily be a roster to you. There's kind of like a cap for that, right? But this cap right now is at a group level. So even though you may have used up that $57,000, you can start using other people in your clinic's cap, assuming they didn't exceed it. But as of April 1st, 2024, that hard cap will now be changed to a solo level. So each individual physician will have a cap of $57,000. And then if it goes beyond, then it gets clawed back. So, and the other thing to remember is only in-basket services count in the hard cap. So for example, like pain clinics, they tend to use a lot of in-basket codes. Whereas for myself in addictions, I bill a lot of out-of-basket codes, so it doesn't really affect the cap for me. The other thing to remember is because you're responsible for your patients, it can be difficult to take a really long time off compared to working in a walk-in clinic where you do shifts and you can do a shift and be flexible about when you want to work. So you also want to think about your inbox management and whether other people in your group can kind of cover for you. So now let's talk a bit about the FHO-specific billing codes. So I thought a lot about what is the best way to teach this in an organized manner. And so I figured you might as well just start from the very beginning when you obtain a new patient. The premise of FHO billing is to have a patient roster, and that roster is what contributes to your capitation payments every month. So when you're starting off from scratch, you might have a very small roster that's not paying very much. So what I personally did before starting to convert to a FHO is I started off billing as a fee-for-service in my clinic, and that way I get the full billing code instead of the shadow billing code for each patient. So when you are rostering the patient, obviously you start with a meet and greet, and you might bill your A007 or your K131 or /K132 codes for the patient, depending on how, comprehensive your discussion is. And in order for the ministry to know that a patient is rostered to you, you add a Q200 to that particular billing code. And that code is paid at 0. And if that patient is coming from a long-term care home, then you would add Q202 when you bill on your EMR system. You want to remember to have the patient complete something called a patient enrollment and consent form, because that is the physical form to show that they are rostered to you. And it will also be later important to have this form when it comes to the virtual care codes as well. Now, let's say the patient is unattached and they were admitted to an inpatient unit in the last 3 months. Then instead of adding the Q200, you would add Q023 as your visit code. You might see that in the previous, that FHO billing document that I showed in a previous slide, you might find that there are codes like Q013 or Q033. Those now no longer apply. So I'm just referencing this here as a visual cue from the SGFP document. In terms of preventative care, screening is a big component of working in a FHO. The main thing to note is that these are the most common codes that I tend to bill when it comes to doing your annual physicals. The other thing to remember is often with doing screening, you want to, if the patient is at the right age or has the right risk factors, to remember to also bill some FIT counseling codes for the fecal immunological testing. And then when you send out the FIT kit, this is an out-of-basket code to remember. And then the Q152 is another billing code for when you get the result back from the FIT, and then you are telling the patient of the result. Now, the other billing code I want to draw your attention to is another out-of-basket code, because now that you're in a FHO, you want to be more vigilant of out-of-basket codes. If you have a patient who has diabetes, just make sure that you see them for their first visit in person, where you can bill their K030 and make sure you do a complete diabetes visit. And then after that, when you see the patient again, you can see them virtually if needed. Just have to remember to add the virtual care code K300 for video and K301 for phone. The reason why it's important to bill this K030 code for your diabetes patients is because once you've seen that patient on their third visit, it unlocks an incentive code for people working in a FHO model, for instance, and that is the Q040. And so that gives you an extra $60 for that patient. Now, these are the preventative care tracking codes, and the thing to note is that these codes don't pay anything, right? They just kind of help the system track what percent of your roster has kind of done their preventative screening up until March 31st. The other thing I wanted to point out is that let's say that a certain patient may not be eligible for a particular preventative care screening. So for example, if the patient had a hysterectomy, they're not sexually active, or they had a mastectomy and so on, then you can bill an exclusion code. So the main purpose of these is that once you hit a certain percentage of preventative care screening, then it can unlock certain bonuses, which I'll touch on in the later slides. Some EMR systems can track this stuff without needing you to bill any of these tracking codes. It is obviously very EMR dependent, because some EMRs where you can just enter the pap smear code and then a date, and they can run a search through their EMR. But in other clinics, the EMR may not be able to do this. So for example, let's say if you're using a third-party company to track your billings and your preventative care, they might actually want you to bill the tracking codes to determine if you're meeting your preventative care targets. Now, the preventative care codes is based on an honor system. So it's an honor system to determine what percent of your target population get their preventative care. And I think in April 2024, these codes will become obsolete. They're trying to claw back these codes and the money going towards these codes to go towards developing a complexity modifier. And then the other thing last thing I just want to point out about this slide is if a patient refuses to do a pap smear, for example, then you can't bill an exclusion code. It's only for these reasons that I have kind of outlined in the slide here, where you can kind of exclude them from the percent that you have screened for. The screening activity report is something that you can sign up for. You can just use your OneID to log in and see the screening activity report. And this kind of allows you to see how you're doing relative to your peers, but also to see how much percent of your patients have done their screening. And also what I like about this is if you go through the tabs, you can actually see all of the different patients' names, who hasn't done their screening or who is overdue and so on. And then you can provide that to your office manager to reach out to them and ask them to come in to do their screening. The important reason why we would bill these tracking codes is because they tell the system how much percent of our patient roster has done their preventative care, and then that translates into a bonus. So in around March 31st, because it's an honor system, that allows you to bill one of these bonus, codes. And let's say you meet the 80% mark for basically every single preventative care, or I guess you've done immunizations for like 95% of your children that are rostered, then at maximum you can get about like 12,800 in terms of a bonus that is paid out sometime in April. And I just included the way that you calculate your percentage screened on the slide as well. So like I said before, remember that some of these bonuses will be replaced by a complexity modifier. So when that happens, I'll update the description below in April 2024. Now, the other codes that you have to remember to bill in a FHO model are for vaccinations. So a common one that we often see is for influenza. And how you would bill this in a FHO, it's a little bit different. Whereas when you were in a FIG or a fee-for-service, you might be billing 𝗧cie𝗽𝗶𝗰𝘀, which is this basic fee. Now you are billing 𝗧que590, if that's the sole reason. And you can kind of add it to 𝗧que590, which is the influenza shot code. And then don't forget about so the other thing is don't forget about the preventative care codes. Even when a patient gets the flu shot somewhere else, like a pharmacy or another clinic, and they told you they got their flu shot, you also still want to add that patient as part of tracking for your preventative care bonuses. One other thing to point out I forgot to mention is if your nurse does the shot and you didn't see the patient, then you wouldn't bill a 𝗧que590, right? You might bill the 𝗧gie700 instead, so that is still kind of tracks the flu shot. If you have a well child and they come in for their vaccines, I've kind of listed the codes here. First, you want to make sure you bill your vaccine code. And then if they're age eligible, you want to add on their tracking code. And this is assuming that they have done all of their vaccines and they've been up to date on all their vaccines up to that 18 months mark. And then the other thing to remember, because this is out of basket as well, is if that patient coming in is 18 months old, remember to add on an A002 for doing a nipissing screen. The other thing to remember is that if you have a child that's coming in that's less than 1 year old, you can also bill a Q015. So this gives you an additional a little bit of a bonus, up to 8 times you can bill this for all of those newborns that you see, because you see them quite frequently. Now, what about evening, weekends, and holidays, right? This is something that is characteristic of working in a FHO, that you have to provide evening and weekend coverage. So the Q888 is actually a new code that they introduced in July 2022 for seeing rostered patients on holidays and weekends. And this is as part of the mandatory after-hours shift that you have to do while working in a FHO. In order to bill this code, you have to have at least 3 pre-booked slots where the patient is where you would bill 𝗧𝗧𝗧. So this would be a pre-booked, and then the rest could be like any sort of walk-in rostered patient. And so this code, you can bill for the rest of the other patients, not for your 3 pre-booked patients, where you get the shadow billing of 𝗧𝗧𝗧, for instance. And this code is out of basket. If you are seeing a patient in the evening after 5 p.m., then you can add on a 𝗧će billing code. And the other thing to keep in mind is sometimes you might hear about the 𝗧888 billing code. This code is now, it's to avoid confusion, 𝗧888 is different from 𝗧𝗽𝗶𝗰𝗀. If you are, let's say, working in a separate walk-in clinic and you don't want to dock any of your FHO colleagues from their access bonus, then you can potentially bill the 𝗧888, and that prevents negation of your access bonus. So for more information on this, I've kind of linked the document or the bulletin that explains this new code that was introduced. Now, you'll also have some patients coming in who might have certain chronic diseases, and there are codes that are specific to FHOs for that as well. The ones I wanted to highlight for you is firstly the heart failure management incentive, which gives you $125, which is a good bonus to have when managing a patient with CHF. And in order to bill this, you need to be able to complete their CHF flow sheet, and often your EMR system might actually have that in there already. And you need to have billed 2 of those CHF diagnostic codes to bill that bonus incentive. Yes, this code can be combined with the after hours code, the 𝗧će for a bit of a 30% bonus on top of that if you saw this patient after hours. The other code to point out is the smoking cessation counseling fee, which you can combine with a 𝗧𝗃𝗃, which is the smoking cessation follow-up code. This code gives a bit of a bonus to folks working in a FHO model. Now, something I just wanted to point out is that when you see a patient for the first time for some issue and they bring up that they are a smoker, or you bring up in the conversation that they're a smoker, and this is the first time that you're talking to them about smoking, you talk to them about whether they want to stop and the options to stop smoking, you can add on the 𝗧𝗃𝗃 code to your visit code 𝗧𝗃𝗃𝗃, for instance, kind of to cover that additional conversation you had with the patient. But let's say if the patient comes and sees you later on in the future and you have a dedicated visit just to talk about smoking, then you can bill this 𝗧𝗃𝗃𝗃 smoking cessation code with the 𝗧𝗃𝗃𝗃. Keep in mind that the 𝗧𝗃𝗃𝗃 code is not a code you can combine with something like an 𝗧𝗃𝗃𝗃. That's why I suggest booking a separate dedicated visit just to talk to the patient about smoking. So to incentivize comprehensive care in the area of home visits, long-term care, labor and delivery, and palliative care, the FHO model has access to some premiums when it comes to incentivizing those areas of comprehensive care. So the first premium that I want to point out is when it comes to prenatal visits, and you can try to bill these codes for visits with pregnant patients. These are all out-of-basket codes. So the thing to keep in mind is that if you bill more than 5 of these for FHO enrolled patients in their first 28 weeks of gestational age, then that opens up a $2,000 bonus that you can get. Now, when you are doing pregnancy care, like you're actually helping to deliver the baby, you can get access to some of these particular codes. So the P06, 7, 9, and 18, and the 20 surgical assist codes. Being able to build these codes allow you to end up with a bonus of $5,000 if you have billed them for more than 5 patients, or $8,000 if you've billed them for more than 23 patients. So if you have an interest in OB, or you have a lot of OB patients, it might be a good idea to join a FHO because a lot of these codes are out of basket. And I guess the good thing is if you see a certain number of these patients, it allows you to get that annual bonus. So And just remember from the previous slide, if you are seeing them for the prenatal care, you also can get a $2,000 bonus on top of that as well. Now, termination of pregnancy. These codes are not listed on the SGFP document, but I want you to know about them because they are out of basket. So if you do have that interest in OB and you want to counsel the patient, or if you're giving them a medication, you're following up on them up to 2 visits per pregnancy, these are the codes that I've listed on this slide. Now, if you do palliative care and you also work in a FHO, there are some additional bonuses that you get when you build these particular codes, which I've just put on the slide for your reference, and I've kind of pointed out to each of them with arrows here. This allows billing these codes for more than 4 patients, opens up a bonus of $2,000, and if you've billed these codes for more than 10 patients, it opens up a bonus of $5,000. Now, if you'd like to do home visits, there are also premiums that you can get for doing home visits as well. Keep in mind that on your SGFP document, you'll see the A901 that is now obsolete. So it's A900. So when you bill, let's say, these codes for more than 3 patients, for instance, you would get a bonus of $1,500, and then so on and so forth. It comes with an increasing bonus with that as well. So if you work in long-term care, it's the same idea. So if you bill certain long-term care codes for a certain minimum of patients, like 12 patients, then that unlocks another bonus for you as well. And then finally, if you do procedures or you have a procedure clinic as well, if you build more than 1,200 in procedures for your enrolled patients, then that gives you a bonus of $2,000. So there are a lot of bonuses out there for various different aspects of providing comprehensive care. And then finally, if you also provide hospitalist care, for instance, and you, let's say, build more than 2,000 in hospital care codes, and I've listed these codes on the slide here, this can give you a bonus of $5,000. Now note that this also includes newborn care, so H001, as well as care for newborns in their 6th to 13th week of gestational age. Care for pregnant people of 6th to 13th week gestational age. That would be a C007. The other thing to kind of point out is the A933 is for an on-call assessment. A C005 is for a consultation, and C003 and 4 are general assessment and reassessment codes for non-emergency hospital visits. So if you are also in a rural area, that opens up a rurality bonus, and you will probably know if you're in a rural area if your rurality index is more than 39, and that you can find out before you decide to locum. You can ask the particular clinic, or you can look this up online as well. Finally, there is also a mental health premium too. So if you have enrolled patients that have bipolar disorder or schizophrenia, then there isn't really any, billing code, I guess, that this is tied to. So you have to bill the tracking code for the system to know that you saw a particular patient that is bipolar or that has schizophrenia. And so if you, let's say you saw a patient, you add on a Q020, you also build the visit code with the diagnostic code for bipolar disorder or schizophrenia. And let's say you've billed 5 of those, and then that gives you a bonus of $1,000. So the final bonus that is available to FHO doctors is the administrative bonus. And this is known as the group management and leadership payment. So this can show up on your RA if you are the FHO lead or the FHO vice lead. And it comes up to be about $1 per patient to a max of the $25,000 that gets paid to the FHO. So this is a bonus for you to help do the administrative work of managing the FHO. And sometimes there are third-party companies that can help with managing the FHO. And so there are also bonuses that can go to them as well. So in my next video, I'll be going over some of the practice cases. And hopefully, if things were very confusing to you in the beginning, by doing the practice cases, it will really solidify a lot of the info for you and help you understand how billing codes and how combining billing codes work. And a lot of the practice cases were tested on family medicine residents at the Sunnybrook Family Medicine site. So you can kind of see how you score compared to what they ended up choosing as their answer as well. So I'll see you in the next video. Thank you for watching.